Thank you for asking me to give a talk. This is going to be an update in vasculitis management. My name's David Jayne. I'm a nephrologist and I work in Cambridge in the UK. And we have a large biomedical campus around an hour north of London. I'm going to cover epidemiology and pathogenesis, review standard of care treatment and some recent advances. We still classify vasculitis according to the predominant size of vessel involved, large, medium or small. But for the nephrologist, most of the vasculitis work is the small vessel vasculitides, those associated with ANCA, typically poor C immune on biopsy, and the immune complex where you see immunoglobulin and complement deposited. This talk is going to focus on ANCA vasculitis, which is the most common presentation in adults. We recognize three overlapping clinical syndromes: GPA, usually with PR3 ANCA, 70% renal; MPA, usually with myeloperoxidase ANCA, 90% renal; and EGPA, as was Churg-Strauss, is only ANCA positive in a minority and 15% have renal disease. We recognize that there is a renal limited variant, which may be ANCA negative, and that there is a respiratory tract variant, which may also be ANCA negative. In terms of the frequency, the incidence in the United Kingdom is 20 per million, with a prevalence over 300 per million. Similar figures from North America and Japan, although in China and Japan, the predominant phenotype is MPA with MPO ANCA. There is a phenotypic spectrum with granulomatosis at one end, typically involving the respiratory tract, and vasculitis at the other end, typically involving the kidneys, but it could also involve nerves, alveolar hemorrhage, and so on. The granulomatous diseases tend to be associated with proteinase 3 ANCA and have a higher relapse risk, but a lower risk of progressive renal disease. But this is a heterogeneous condition. There have been advances with the genetics. There are genetic polymorphisms underlying proteinase 3 and MPO ANCA that associate more closely with the autoantibody subtype than they do with the clinical phenotype. So there are distinct HLA-DP associations with PR3 and DQ with MPO. In future, we are likely to classify patients based on their autoantibody specificity. Key points about pathogenesis are a recognition of the importance of B cells, which can be seen at sites of inflammation, along with activated plasma cells taking part in the granulomatous lesions, for example. The evolution of the glomerular lesion starts with a foci of necrosis in the glomerular tuft, here demonstrated by fibrin deposition. This elicits an intense epithelial and macrophage dominant reaction, which is formed the crescent. Here's a slide showing the macrophages. This can lead to glomerular rupture, collapse of the tuft, tubulointerstitial nephritis, and subsequent sclerosis. And on a renal biopsy, you typically see glomeruli at various stages of this sequence. Although immunoglobulin and complement are rarely seen, you can see complement split products such as BB, C3d, and the terminal attack complex C5b through 9, highlighting that complement may play a role in pathogenesis. This is data from an experimental model where taking out the C5a receptor abrogated disease, and using a drug, CCX168, now called avacopan, that inhibits this receptor, there were no glomerular crescents. We think complement is playing a role in a feedback loop whereby you have ANCA activation, neutrophil activation, binding of ANCA, endothelial injury, release of nets, which serve as a substrate for more complement formation and platelet activation. In terms of outcomes, this is population data from Sweden showing the excess outcome in terms of survival of patients with ANCA vasculitis compared to controls. And this is largely driven by subgroups that have renal disease. this emphasizes the importance of early diagnosis of renal disease to improve survival risk. Other key prognostic factors for end-stage renal disease or survival are GFR at presentation, MPO-ANCA have a worse prognosis, older age, concurrent anti-GBM, and comorbidity. There are various scores which assess the risk of end-stage renal failure based on the biopsy findings. The original Bairden classification using European Vasculitis Society data. There's a Mayo Clinic system and a more recent system from Germany, which bring in tubular changes and renal function to the prognosis score. But the histology is primarily to diagnose the disease, and these scores do not dictate treatment. It's important to recognize that the disease burden patient suffers from is multifaceted, and these different components a major influence on our longer-term management of patients. And I highlight relapse, organ damage, and comorbidities occupying much of our time. This is data on long-term outcome of vasculitis patients looking at damage, and makes the point that some items are related to disease, such as reduced GFR, and some are treatment-related, such as steroid-related complications. We're very aware of the 10% risk of thromboembolism within the first year of diagnosis and 14% risk of stroke and myocardial infarction. And currently, the causes behind these frequencies are not fully understood, and we don't have good interventions to try to reduce this risk. But you need to be aware of these events in your patients. Moving to standard of care treatment, patients with nephritis will often have a rapidly progressive phenotype with blood and protein in the urine, but they may present with nephritis with a normal GFR, either through urine screening or because they presented with another inflammatory manifestation and have had their renal indices checked. If you microscope urine and you see red cell casts, then it's very likely to be a crescentic nephritis. You may also see dysmorphic red cells indicating glomerular origin, and kidneys are usually of normal size. However, we also recognize some harder to diagnose phenotypes, such as what we call a slow burn. These are patients presenting with chronic kidney disease, have relatively modest abnormalities in the urine, and a lot of glomerular sclerosis on biopsy. This is a particularly common phenotype in the elderly. There may be a delayed nephritis, so these are patients who present with respiratory tract disease without renal disease, who develop nephritis usually within 18 months of diagnosis. Some patients are ANCA negative, and then we see overlaps, for example, with lupus, IgA nephropathy, or anti-GBM disease. When you're investigating a patient, they require a full immunology workup. But really, in addition to making the diagnosis, the purpose of the investigation is to determine the extent of the disease. And here are some CT cross-sections showing different manifestations of pulmonary disease. But it is also to try to identify the 4 or 5% of patients for whom vasculitis is a secondary disease, secondary to either drugs, such as cocaine or propylthiouracil, underlying malignancy, or infection. And we particularly worry about tuberculosis and chronic viral infections. In terms of the use of ANCA, this European study found that the commercial proteinase through an MPO assays perform very much better than ANCA indirect immunofluorescence. And we recommend that the ANCA assay you should request is the PR3 and MPO ANCA assay. And in a patient with suspected nephritis, if this assay is positive, they're quite likely to have the diagnosis, over 95%. It's important to start treatment as soon as possible. And this raises the question of when can biopsy be avoided. And I proposed a simple algorithm that if it's a clinical presentation, which is typical for the disease with an experienced center, then you can press on without biopsy. But if the ANCA is negative, or if there are suspicions of a secondary vasculitis, then you should biopsy. In patients who've not had a diagnostic biopsy, who have a poor treatment response, then you can do a delayed or protocol biopsy 8 to 12 weeks after diagnosis. So turning to drugs, while the standard immunosuppressive we use is cyclophosphamide or rituximab, we have looked at a role for mycophenolate, rather analogous to lupus nephritis. And this study found initial response rates at 6 months, but at 18 months, the MF group did much worse, particularly for those with PR3 ANCA. So we do not recommend mycophenolate for PR3 ANCA disease, but a minority who had MPO ANCA did equally well in both groups. Rituximab is really becoming a preferred treatment because it will avoid the toxicities associated with cyclophosphamide. This is recent data of the effectiveness in relapsing GPA and MPA. In this trial, ritaziram, 190 patients were included, and 91% had achieved remission by 4 months. So it's remarkably effective for relapsing disease. Many recent trial efforts have been aiming to reduce steroids because we recognize steroids as being the main driver of toxicities. The Pexivas trial addressed 2 questions. Firstly, plasma exchange, which I'll discuss in a minute, and secondly, whether we can reduce steroids. And we recruited 700 patients with a GFR less than 50 mils a minute. And this was led by Mike Walsh from Hamilton. So in terms of the steroid randomization, patients either received a standard regimen of 2 weeks of 1 mg per kilo per day, then coming down slowly, or a rapid reduction after a week of higher dose steroids, such there's approximately a 50% difference in exposure. In terms of the efficacy, we saw no difference in the proportion developing death or end-stage renal disease, but we saw a reduction in serious infections in the first year. So the reduced dose regimen is now the recommended oral prednisolone regimen. There has been interest for some time in looking at the combination of rituximab with cyclophosphamide, particularly for those patients presenting with a low GFR. And we studied this in the rituximab trial a number of years ago. But this has been developed by a London group led by Pepper, who've shown that the combination can be steroid sparing, and they've reduced the total dose of IV and oral steroid to 1,200 milligrams, removing steroids after 2 weeks. And in these graphs, comparing their data in the solid line with matched controls from historic cohorts, they find, if anything, better long-term outcomes. But this combination does require further trial evaluation. For the most severe disease, we've considered plasma exchange, which brings me back to the Pexivas trial, which overall did not find a significant benefit of plasma exchange on the composite of end-stage renal disease or death. But in the first year, the no plasma exchange line shown in blue had a higher risk of death or end-stage renal failure, but the difference was lost over time. Mike Walsh has performed a meta-analysis for the single endpoint of end-stage renal disease, and he has produced conclusive evidence that there is a benefit on risk of end-stage renal disease. But this is only clinically useful for those presenting with a serum creatinine above 500 micromoles per liter. But plasma exchange could be considered in cases below that who are rapidly deteriorating. So what do? I give IV steroids straight away. I use the Pexivas reduced dose regimen. And we often give, especially in the COVID era, the combination of rituximab and cyclophosphamide ×2 because it minimizes visits to the hospital. Plasma exchange if there's creatinine over 500 or if there's hypoxic lung hemorrhage. We modify our regimens for the elderly over 80, where we try to avoid cyclophosphamide and use less steroids. And in those with more modest presentations, we just give rituximab and a lower dose of oral steroid. In terms of maintaining remission, concepts you need to be aware of are that patients will vary in terms of their risk of relapse, depending on their baseline features, some of which I discussed earlier, And then the consequences of relapse are going to vary between patients. And there are some patients in whom relapse will not induce lasting damage, and there are others in which it will. In the standard therapy, we've used combination of oral immunosuppressives and steroids, but have not known how long to treat. The Remain trial simply showed that if you gave for 4 years, the blue line, you had fewer relapses than if you gave for 2 years, here recruiting patients after 18 months. And this actually fed through to fewer patients with end-stage renal disease at 4 years. I think one of the take-homes from this trial is that if you're going to stop therapy at 2 years, you have to accept an increased relapse risk and monitor accordingly. But we now have 2 trials demonstrating that rituximab is superior for maintenance than these previous regimens, typically with azathioprine, the Main-Ritson trial and the rituximab trial. The Main-Ritson recruited new patients after cyclophosphamide induction, whereas rituximab focused on relapsing patients who had rituximab induction. But essentially, both trials showed the same thing. Fewer patients experiencing relapse in the rituximab groups compared to the azathioprine group. The problem is what happens when you stop rituximab. So this is data on the left from the rituximab trial. They stop at this vertical line, and after about 6 months, they start relapsing, and the relapse rate parallels the azathioprine group. There has been an extension to the French study where they continued dosing rituximab out to 4 years and found that this continued to be effective, the solid line, compared to those stopped at 2 years. So this is currently the debate. When do you stop rituximab? Can biomarkers guide rituximab dosing? The short answer is, I think no. In terms of ANCA, around 50% become ANCA negative after rituximab, and these do have a lower relapse risk, shown in the red line on the right graph, as opposed to those that remain ANCA positive. But ANCA is relatively insensitive for relapse, as are B cells. And although in a cohort, B cell return tends to correlate with increased relapse risk, for individual patients, there's quite a variance. Other problems with rituximab are that we have around a 20% remission failure for new patients. The relapse rate, if you stop rituximab, I've already mentioned. I've mentioned about the inefficacy at inducing ANCA negativity, but the biggest problem is immunodeficiency. And patients with vasculitis receiving repeated cycles of rituximab have a risk of becoming hypogammaglobulinemic. And this is a graph of the number of patients in my clinic on replacement therapy for rituximab-induced hypogammaglobulinemia. So what I do, if patients have had cyclophosphamide induction, we still use oral immunosuppressives and low-dose steroids. But increasingly, we're using rituximab, and we give 1 gram every 6 months, but 500 milligrams is probably just as good as was given in the French study. And the key thing, if you're going to use rituximab, is that you can stop steroid and you don't need to use an immune suppressive. And this is attractive, particularly attractive to patients. It's important to monitor IgG levels, monitor ANCA, but I do not routinely monitor B cells. We modify this recommendation where we consider there's a low relapse risk, for example, an MPO ANCA patient who's become ANCA negative, and then we may stop after a year. We try to minimize rituximab if IgG is less than 5. And if there's a relapse after stopping a course of rituximab, and that's at least a year after the last dose, then we put the patient on annual infusions. If patients are not responding to rituximab, then consider, in this situation, checking B cells, looking for underlying infection or malignancy, shortening the interval between infusions, and rarely, but this really is relatively rare, combining rituximab with low-dose oral immunosuppressives. So to finish on some recent advances, I mentioned in the pathogenesis section that complement was involved in terms of deposition in the kidney and the experimental data preventing experimental nephritis. So just as a reminder, The complement system has an afferent pathways, an amplification loop, and then the effectors C3 and C5. C5 two subcomponents, C5a and C5b, and eculizumab, with which I'm sure you're familiar, will block both C5a and C5b pathology. The latter is necessary to protect against Neisseria meningitidis, which is the reason for the black box warning for eculizumab. A variety of drugs have been developed to block C5a, either antibodies, which will block neoepitopes that form on C5a after cleavage, or drugs such as avacopan that block the receptor. It's important to note there are two C5a receptors, C5a receptor and C5L2, and there's some evidence that the second receptor is regulatory, so there may be theoretical advantages to avacopan over C5a antibodies. A phase 2 trial called CLEAR comprised 3 groups. Those patients treated with standard dose steroid, shown in grey, those treated with low dose steroid and avacopan in green, and those just with avacopan in red, all patients receiving a background of cyclophosphamide or rituximab. It was notable the speed with which proteinuria fell in the avacopan groups, and we saw similar effects on hematuria and markers of macrophage activation. Also, quality of life shown by EQ5D, or short form 36, was significantly better in the avacopan alone group, perhaps reflecting the lack of steroid. This led to the design of Advocate, a phase 3 clinical trial published last month. This randomized over 300 patients to either avacopan, here called CCX168, or to steroids, tapered to 0 by 5 months. All patients receiving a background of rituximab or cyclophosphamide. I'm showing you here the primary endpoint at week 52. There was an absolute difference in sustained remission of 12.5% in favor of the avacopan group, which met the statistical definitions both for non-inferiority and for superiority of the avacopan group over the prednisone group. In terms of secondary endpoints, avacopan was more effective at preventing relapse, shown in this graph, and was more effective in terms of kidney recovery. Now, only 70% of patients in this trial had nephritis, but overall, there was better improvements in renal function, shown here at week 26 and week 52, in the avacopan groups shown in red, as opposed to the prednisone group shown in grey. This graph shows the change in GFR over time, with the curves opening up after about 12 weeks. And overall, there was around 3 to 4 mils a minute better recovery in the avacopan group, which rose to about 8 mils a minute better recovery for those with a GFR below 45. So I've taken you through an update of recent advances in vasculitis. I've touched on classification and pathogenesis, and we're anticipating revised classification criteria emerging from an ongoing project called DCVAS. I've mentioned the genetic polymorphisms that underlie the disease and their close association with ANCA subtype, and I've touched on B cells and complement in pathogenesis. In terms of outcomes, the GFR at diagnosis is critical, which feeds through to the importance of making early diagnosis and early referral. Comorbidities are important in this patient population, and in addition to the cardiovascular morbidities I mentioned, infections are very frequent, as are malignancies. In terms of treatment, I've given some recent data on immune suppressives, the mycophenolate study, and the longer-term study, 4 years versus 2 years of oral immunosuppressives, and the recent data with remission maintenance with rituximab, which is now a licensed therapy for remission maintenance in many countries. I've highlighted some of the problems with rituximab, such as what happens when you stop it, the problems of a secondary immunodeficiency with repeated doses, but it does give you the advantages that you can often run your patients free of steroid and oral immunosuppressives. And then I've closed with the exciting data from the avacopan studies, which perhaps heralds a new future for the treatment of vasculitis without steroids and with even better renal response rates than we've had to date. I would like to highlight that much of what I've said will be covered in the KDIGO 2021 guideline for the management of glomerular diseases, which is currently in press. And I would like to acknowledge all my colleagues in Cambridge and members of the UVAS and VCRC networks who contributed much data to the talk.